the major reason for the weight regain is that the person who's lost weight has an increased desire to eat. And it's not reasonable, in my view, to expect people not to eat when they're hungry. And in our societies now, we're surrounded by food. So if diet composition at best has only a minor impact on whether you lose weight or maintain weight, is there a better way to lose weight? In my view, it is best to lose weight rapidly rather than slowly. And the clinic that I run in Melbourne, we, as a matter of routine, place all the patients that we see initially on a very low energy diet unless there's a contraindication to do so. VLED is a total food replacement intended to achieve significant weight loss without risk of severe negative nitrogen balance or electrolyte disturbance. It's usually a nutrient mixture based on egg and milk protein. It does have some carbohydrates, but it has also essential fatty acids, vitamins and minerals. And it gives between 400 and 800 kilocalories a day. And you can either replace 2 or 3 meals a day. This diet induces ketosis, and there's enough circumstantial evidence and that ketosis suppresses hunger. So during this diet, the individuals shouldn't be hungry. Now, you can see that the VLEDs do achieve, and this is the meta-analysis I showed you before, a lot more weight loss than the others. But of course, these individuals, if left alone and if without any intervention, do regain just as everybody else does. But the question is, in this particular study, as I said, this was a meta-analysis, but there were no head-to-head studies. We are in the process of conducting a head-to-head study that we presented the preliminary data at the International Congress of Obesity this year, but I'm going to show you now the updated data in terms of weight loss. We asked the question, does the rate of weight loss impact on achieving weight gain and then maintaining weight gain? The primary endpoint in this study is to see what the weight is at 3 years, but of course I can't give you that information yet. I'm only going to show you in terms of achieving 15% of weight loss. It was a randomised dietary intervention trial, and the individuals had to be agreeable to be randomised. We randomised 200 subjects, 100 or 97 in the rapid weight loss program over 3 months, and 100 into a gradual weight loss program over 9 months. We had the usual inclusion and exclusion criteria. I don't have time to go into that detail. The rapid weight loss group during the weight loss phase had a very low energy diet plus exercise with bi-weekly visits to the dietitian, and they were required to lose weight at 1.5 kilograms a week, whereas in the gradual weight loss group they had the healthy eating program as by the Australian Guide to Healthy Eating. They also had the same frequency of visits, and they had to lose weight at 0.5 kilograms a week. Looking at the rapid and gradual weight loss group, there was no difference. They were well matched for age, sex, body mass index, weight, and fat-free mass. And this is what we found. We found that nearly 80% in the rapid loss group achieved 15% of body weight, compared to only 52% in the gradual weight loss group. We had a higher dropout rate in the slow weight, gradual weight loss group. Only 3% dropped, 3.1% dropped out in the rapid weight loss group, compared to nearly 17% in the slow group. So losing weight slowly, losing a target weight slowly is more difficult is more difficult compared to losing it rapidly. Now, of course, this is what we've shown, that doing it this way is more likely to achieve success. But at this point here, in my view, what we need is pharmacotherapy. Pharmacotherapy is not needed to lose weight, as these studies demonstrate. The companies will sell you the drug to lose weight, and even the FDA wants a drug for weight loss to be confirmed that it can cause weight loss. We don't need drugs to lose weight, but we must have drugs to keep weight off. Why? Because we need to counter those hormone changes that occur that make us hungry. And of course, drugs like sibutramine, which has just recently been taken off the market, has been shown to assist with weight maintenance compared to the placebo group, which weight regain. Now, we desperately need development of new pharmacological agents, preferably analogues of those hormones, or even leptin and amylin combinations, for example. So to conclude, the specific composition of weight loss diet is not critical. To achieve weight loss, it is essential to reduce intake below expenditure. You've just got to reduce your caloric intake. Weight is regulated, and following weight loss, physiological changes favour return to baseline. There are some advantages in achieving weight loss rapidly with a ketogenic diet, but the problem of weight regain remains unresolved because of lack of suitable pharmacotherapy. And before I finish, I'd like to thank the 3 PhD students that have done much of the work. Dr. Prendergast is a statistician. Celestine is a medical student who did some work with us. And these are 2 lab technicians who've done the hormone assays, and acknowledge the granting bodies, and also Nestlé Australia for supplying the Optifast to our patients. Thank you very much.